So today we are going to be talking about this OSC. So we are on surgery OSC 3. So this is our third surgery OSC session. So let's start with session 1. So it's saying about perforated peptic ulcer disease. So question 1. What is the causative organisms for PUD, that is peptic ulcer disease? And what are the risk factors of developing PUD? Then what investigations will you do order for suspected perforated PUD? Then question 4. What pathognomonic features would you see on chest X-ray of perforated PUD? And 5. What is the surgical management of perforated PUD? Then question 6. Name the classification used to classify bleeding or bled peptic ulcers. So this is the question. So here the answers are. So what is the causative organism? So the causative organism is Helicobacter pylori. Then the risk factors, we have stress, alcohol, smoking, acidic drinks, NSAIDs, steroids, and also a Helicobacter pylori infection. Then we have age. So for the age, duodenal ulcers are common in those 30 to 40. Then gastric ulcers are common in those who are over 50 years. And then we also have acid hypersecretion, for example, in Zollinger-Ellison syndrome. Then what investigations? So for the investigations, as long as you can see the air under the diaphragm part, so you can even do a plain X-ray abdomen. But me, I would prefer for an erect plain chest radiograph, since you are specific for the air under the diaphragm. So I would prefer you do an erect plain chest radiograph. So the chest X-ray is just easy for you to remember, because the plain X-ray abdomen, they might end up just in order for that, they might end up just doing for the they will maybe leave out the part of the diaphragms. Maybe they just focus on the below the diaphragms, and you want to maybe they will skip the diaphragms. So a chest X-ray would be ordered for suspected perforated, so that you see under the diaphragm. Then the pathognomonic feature on chest X-ray, like I've said, A under the diaphragm. So right, A under the right hemidiaphragm. That's the pathognomonic feature you want to see. Then surgical management. So surgical management of perforated PUD, we can have a Rosé-Gram operation, or you can say emergency laparotomy or laparoscopy. Or occasionally the patient is seen who has a massive duodenal gastric perforation, such as simple closure is impossible. So in these patients, a Burroughs 2 gastrectomy is a useful operation. So that's some of the surgical management. It's not just one. The name of the classification used to classify bleeding or bled ulcers. So we have Forest classification. So that's the name of the classification to classify bleeding or bled ulcers. Then station 2, how do you classify burns? What are the 6 admission criteria of burns? Formulate the Parkland's formula for fluid in burns. Then mention 4 complications of burns. So how do you classify burns? So we have superficial burns, which were known as first degree burns. So it involves the epidermis only, no blisters, reddish or erythema. They are painful, so if you do a pin prick test, it's going to be positive. In short, there is going to be severe pain to prick. Then how does it heal? So it heals by rapidly by reepithelialization with no scars. That's first degree or superficial burns. Superficial burns. And then we have the second degree bends, also known as, or they are now known as, partial thickness bends. So in partial thickness bends, we can have two, A and B. So A is superficial partial thickness, and we have deep partial thickness. For superficial partial, it involves the epidermis and the papillary dermis. Then it is also red, it is blistering, it is moist, painful, and healed by epithelialization, and completely healed by 14 days. And there is a minimal or no permanent scars, but can leave discoloration. So we're done with superficial partial. And then for deep partial, it involves the epidermis, the upper dermis, and the varying degrees of the lower dermis, so in short, the reticular dermis. And then it looks pale, mottled, it has a mottled appearance, and there is a fixed staining, so meaning no branching. So when you press on the skin, it won't be branching. That's what it means. Then it may be painful or insensitive, depending on the depth. Then how does it heal? So we said the superficial burns. Let's just do a recap on the healing. So superficial burns heal by the epithelialization. Then superficial partial heal by epithelialization. We remove the re, it's not just epithelialization. Then for deep partial, they heal also by epithelialization, but you combine with the wound contracture. So they heal by combination of epithelialization and wound contracture. And it may take weeks and can leave significant scars and contractures over joints depending on time taken to heal. Then we have the last classification of full thickness burns, where we have third degree burns, where we have both dermis and epidermis bent. Then there are no blisters, skin appendages are bent or damaged. Then it looks dull or dark. Then the pinprick sensation is negative. Then pressure to the limb may be present. That's the classification of burns. So superficial burns, partial thickness burns, and full thickness burns. Admission criteria. So on the admission criteria, we have in adults, admission criteria is 20% burns, body surface area. In other literatures will tell you 15 to 20 total body surface area. Then in children, they all stick with more than 10% body surface area. So meaning when someone comes less than 10, they don't admit. The admission criteria for burns in children is more than 10% superficial burns. Then the other indication is burns involving the face, hands, feet, joint, and genitalia. So meaning you don't have to wait for it to be 10% and for you to admit, but as long as it's involving the face, hands, feet, joint, genitalia, you have to admit, even if it's less than 5%. And then for suspicion of aeration burns, you can admit. Chemical and electrical burns, you admit. Burns in extremes of age, you admit. Also circumferential burns, you admit. And also the burns where the psychological or the psychological status or mental status of the patient is in question, you also have to admit. Okay, then Parkland's formula, how do you formulate it? So Parkland's formula is equal to body weight times TBSA times in brackets say 2 to 4 mils, and it's going to give you X mils. So the answer was, the question was just how to formulate, but maybe let me share also how to give. So first, give half of X mils in the first 8 hours from the time of Ben's event. Then second, the last half we are going to give it in the next 16 hours. Okay, that's how you give. Then let's say your answer was 1000 and the child was bent around 10 hours, then they came even at the same 10 hours. So we are going to get half of the 1000, which is our X meals, which is going to give us 500. So meaning we're going to give 500 in the first 8 hours, and the other 500 in the next 16 hours. But if the child was bent around 10 and they came at 14, meaning 4 hours has already passed, so just give the remaining 4 hours the first half. Then in the other half we're going to give in the next 16 hours. Okay, so we are done with the bends. So no, we are still on the bends, now on the complications. So complications in surgery, we have AD, where we have respiratory system, we have airway obstruction due to inhalation bends, which causes pulmonary edema, ARDS, and respiratory arrest. You can have breathing difficulties as a result of respiratory distress due to air around the neck. Then under CVS on the air complications, we can have edema due to the release of inflammatory mediators to produce vasoconstriction, and vasoconstriction to produce vasoconstriction, and there is also vasodilatation, which leads to increased capillary permeability, meaning there will be extravasation of fluids from the IC intracellular space to the extracellular space. Then hypovolemia due to fluid loss as a result of the increased capillary permeability, like I was saying, increased capillary fluids will start moving. There will be loss of fluid from the intracellular to the extracellular due to the increased capillary permeability, due to SIRI, systemic inflammatory response syndrome, and this may lead to renal failure. Then C, it can lead to hypoxia due to destruction of red blood cells, because thermal injury causes coagulative necrosis to the epidermis and underlying tissue. Then D, can have shock. So shock due to systemic inflammatory response syndrome, or due to an inflammatory response causing release of inflammatory mediators like cytokines, which lead to vasodilatation in bent areas. Then the last point on CVS is toxic shock, which can occur if there is a 20% bacterial infection causing bacteremia. Then under the MSS, you can have hypothermia as a result of loss of thermoregulatory function of the skin due to damage. Then GUS, we can have a fluid and electrolyte imbalance due to dehydration, hyponatremia, hypokalemia, and hypocalcemia. Then we have metabolic, where we have hypoglycemia due to hypercatabolism and mobilization of glucose as a result of release of stress hormones. So that's hypoglycemia under metabolic. Then we are now done with the AD. So under intermediate, we can have wound infection due to damage to the protective function of the skin. We can have septicemia, we can have anemia plus malnutrition due to hemocoagulation. We can have stress ulcers, which are also known as Kering's ulcers. You can have paralytic ileus due to electrolyte imbalance. You can have compartment syndrome due to Asia or slough which is produced. Then you can have poor healing and ankylosing or joint stiffness. You can have renal failure, septic arthritis, hypoproteinemia, ectropion, which is the retraction of eyelid. You can also have amputation under intermediate. Then late, you can have contractures, hypertrophic scars or keloids. You can have Majolling's ulcers. You can have Majolling's ulcers, which are also known as malignant ulcers. You can have nerve compression, psychological effects, or cosmetic effects. We are now done with the session 2. Session 3, what is skin grafting? Indications of skin grafting. Mention 4 causes of skin graft rejection. Mention 5 complications of skin grafting. So the session 3, so skin grafting in its basic sense is transplanting of skin. So we can define it as detaching a sheet of skin from its own blood supply and placing it in a new area of the body. Then indications of skin grafting can have acute skin loss in, let's say, in flame burns. So when someone comes with full thickness burns, if you want to accelerate healing, you can just do a skin graft. So that's the flame burns, friction burns as well. Then you can have in chronic skin loss, such as in chronic leg ulcers or adjunct to some procedures, e.g. in skin excision. If it's a well granulated ulcer, you can do. Then you can have a clean or defect which cannot be opposed, a clean wound or defect which cannot be opposed. Then you can also do after surgery to cover and close the defect created, e.g. after wide excision in malignancy. So after surgery to cover and close the defect created. So examples: after wide local excision, or after wide excision in malignancy, after mastectomy, after wide excision in squamous cell carcinoma graft. So that's some of the indications. Then 4 causes of skin rejection. So you can have infection, poor selection of graft location, and technical error. Then you have these causes of skin rejection that has to do with one, which are called there is one called the hyperacute rejection, which is caused by antibody reaction which occurs within minutes of vascularization of the graft. So this is due to an antibody reaction. Then the other one is acute rejection. So the acute rejection, so we are from hyperacute to acute. So acute rejection is also due to the cell-mediated immunity occurring in a few days to 3 months, to first 3 months of transplant. Then it responds well to steroids and immunosuppressants. So that's the acute one. So this one is caused by cell-mediated immunity. And then we have the last one, which is chronic rejection, which occurs in 12 months after transplant. It is not very common. It is due to vasculitis. And when it occurs, it responds very poorly to steroids or other drugs. So it is a common type. Then complications of skin grafting can have donor site morbidity, graft loss, hyperpigmentation, poor cosmesis, infection on the site. Can also have bleeding, and can also have formation of an hematoma after it has bled. Then additional information: so there are 2 types of skin grafts: split thickness skin graft, SSG or SDSG. Can also what is a split thickness skin graft? So this one does not contain the whole dermis. Then there is another one which is known as a full thickness skin graft, FTSG, which contains the whole dermis, also transplanting hair follicles. Then classification according to their donor sites. So from where you're getting the skin graft. So you can have autograft, isografts, allografts, xerografts. Then we are done. Session 4. Describe what you see. Define necrotizing fasciitis. Mention classification of necrotizing fasciitis. What physical features would you see on necrotizing tissue due to necrotizing fasciitis? What's the surgical management of necrotizing fasciitis? So describe what you see. So from what I could see, I would say there is a deep wound on the anterior part of the chest, then excising. Then if you look at the edges, you can say it's it has well defined edges. I think that's all I could mention, because describe what you see is not cast in stone. So you can just say what you're able to see, but don't say you are seeing a tube. No, just they are asking you about necrotizing fasciitis. Maybe something just has to do with the wound. Okay. So I'll describe what I've seen. The definition of necrotizing fasciitis. So this is a life-threatening, rapidly progressive infection that spreads along the fascia planes and subcutaneous tissue. Then, I don't like putting mostly caused by gas bacteria, but because when you say that it is all right, it is correct, but maybe just define it without mentioning maybe the cause. But I've seen most of my research where they were mentioning a cause, which is a gas bacteria, the group A, streptococcus. Then it can also be defined as a spreading inflammation of the skin, deep fascia, and soft tissues with the intensive distraction to eczema common due to streptococcus infection. But that's most of my research. But me, I'd prefer to not say the causative organism. But most of my research, they were mentioning the causative organism. Yeah, but maybe you say most commonly due to. Yeah, maybe that makes sense. Mention classification of microtizing fasciitis. So we have the microbiological classification, which are type 1 to 4. Then type 1, we have a microbial infection primarily caused by a mixture of anaerobes, e.g. bacteroides, and anaerobes, which is Staphylococcus aureus, which is the more common of the types of the type 1 and type 2. Then this one is common in elderly or comorbid patients. Then type 2 is a monomicrobial infection primarily caused by Streptococcus pyogenes, which is your gas, group A strep. And it's more common in elderly individuals with a history of trauma. Then it can also be caused by Panton Valentin leukocidin PVL, which is also positive Staphylococcus aureus infections. And you can have also some classifications, meaning the type 3 and 4, where you have type 3, which is also known as anaerobic. For example, a gas gangrene is a type 3 necrotizing fasciitis. And we have a type 4, which is marinofungal causes. That's why I said it's fine for you to say mostly caused by, because as you can see, the type 4 one is caused by fungal marine causes. So if you say mostly caused by, it's understandable. But when you say which is caused by gas, meaning it can't be caused by Staph aureus, can't be caused by the PVL. So just say like mostly caused by. Okay, so physical features. So physical features, early signs. So early signs, we can have skin erythema, edema, also signs of ischemia. Then late signs, we can have skin crepitus, vascular. Then we can also have obvious skin necrosis. Then under the surgical management of necrotizing fasciitis, so this is the surgical emergency and needs immediate resuscitation and debridement if this is deemed appropriate. Then the only definitive management is agent debridement, and the same agent debridement has to be done in loops. So agent broad spectrum antibiotics as per protocol. And then, like we've said, the definitive is broad spectrum antibiotic and agent surgical debridement. And this debridement, you have to do it in loops. So you go and the blood, you come and reassess, you take back so that you destroy or you cut out all the necrotic tissue. Okay, then we have section 5. Describe what you see, define osteomyelitis, differentiate involucrum and sequestrum, differentiate acute, subacute, and chronic osteomyelitis based on duration. What is the use of vitamin D and dysfunction in bone healing? What is Codman's triangle? Complications of osteomyelitis. So describe what you see. So from what you've seen here, so you can say, so let's pick out this one. So there is an enlarged bone in terms of width. Then it is also hyperdense. So there is hyperdensity. That's what I would say. But like I said, describing what you see, you are not limited. And the shape is irregular, because this is not how the bone is normally shaped. Okay, so we've described what we have seen. Define osteomyelitis. So This is a progressive infection of bone or bone marrow. Then differentiate involucrum and the sequestrum. So involucrum is the new bone laid down by the periosteum that surrounds the sequestrum. Then while the sequestrum, this is the necrotic bone that is deemed or that is embedded in the pus or infected granulation tissue. So meaning involucrum is a new bone, sequestrum dead bone. Then differentiate acute subacute. So there were different literature. So literature 1 was saying, and this is one which is easy to remember. And literature 1 was saying acute is less than 2 weeks, subacute is 2 to 6 weeks, then chronic is more than 6 weeks. Then literature 2 was saying acute is less than 2 weeks, subacute is 2 weeks to 3 months, then chronic more than 3 months. So this is different in literatures, but the literature 1 was easy to remember because 2 less than 2 weeks, 2 to 6 weeks, more than 6 weeks. What is the use of vitamin D? So vitamin D, also known as calciferol or sunshine vitamin, is a fat soluble vitamin that helps regulate calcium and phosphorus in the body. Then it causes the increase in expression of rank L in osteoclasts and inhibits expression of OPG, thereby stimulating osteoclastogenesis. So it is an essential micronutrient for the maintenance of bone quality and bone healing. It is actively involved in bone formation and mineralization and maintenance of neuromuscular functions. Then it also regulates bone metabolism through activation of the vitamin D receptors found in osteoblasts. And then it is also responsible for increasing intestinal absorption of calcium, magnesium, and phosphorus or phosphate, etc. And then after those have been absorbed, those are so the same calcium, magnesium, and phosphorus. Then the part of the calcium part, when it is absorbed, it facilitates the rebuilding of bone tissue. Okay, so what is Goodman's triangle? So Goodman's triangle is a radiological sign seen most common in musculoskeletal plain films, meaning X-rays. It is the name given to a periosteal reaction that occurs when bone lesion grow so aggressive that it lifts the periosteum off the bone and do not allow the periosteum to lay down a new bone. So this radiological sign classically presents with aggressive primary bone tumors, including osteosarcomas, which is the most common, Ewing sarcoma, chondrosarcoma, and metastasis. Then the reaction derives its name from the Ernest Amory Codman, which is the surgeon who first described it, the finding in an article in 1926 when discussing bone sarcomas. So in short, Codman's triangle is when we have a periosteal stripping. So there is a geological sign that looks like if the periosteum is stripping. So I can just say it's more of a periosteal stripping when you see it, and that prevents the formation of a new bone. And the complications of osteomyelitis, so this we have septic arthritis, septicemia, DVT, pulmonary embolism, pathological fractures, epiphyseal damage and altered bone growth. We can have pyemia, chronic osteomyelitis, which can eventually lead to joint stiffness. We can have sinus tract, Barigras. We can also have epithelioma, can have metastatic infection. So this is what we are talking about. Sequestrum, new bone. Sequestrum is the dead bone, then the new bone is called involucrum. Then the cloaca this is where the os in the bone are. Then session 6, what do you see? What are the general? So general classification of wounds. What are the factors that affect wound healing? Phases of wound healing. So as you can see, so what do you see? Describe what you see. So there's a wound here. So there's an open wound being cleaned. That's what I could detect from this. But like I say, we are not limited to just describing one thing, but don't say there's a dish. Maybe can say an open wound on a basin. At least it makes sense because we have mentioned the first thing we had to see was the wound. Yeah. Okay, so what do you see? What are the classifications? So classification of wounds, we can have classification one, where we can have a simple wound, which is when the only part is the skin which is affected. Then you can have the complex wounds, where we have the vessels, the nerves, tendons, bones are also involved. Then classification two, we can have a Rank and Wakefield classification, which classifies wounds as tidy wounds and untidy wounds. Then we have classification number three, where we have classification of surgical wounds, where we have clean wounds, clean, contaminated, and dirty wounds. So we have clean, contaminated, clean, contaminated, and dirty wounds. Then under classification number four, we can have contusion, abrasion, hematoma, open wounds, incised wounds. We can have lacerated wounds, crash wounds, penetrating wounds, or these contusion, abrasion, hematomas. So that's the classification number four. We can have closed wounds and open wounds. So closed, contusion, abrasion, hematoma. Then open wounds, incision, size, lacerated. Then they can also be classified according to their mechanism. Again, if you classify them according to their mechanism, so this will be our classification number five. So if you classify them according to the mechanism, that's where we can again have abrasions, lacerations, avulsions, and the like. So that's when you classify them according to their mechanism. Then other literatures also can classify them as superficial wounds and full thickness wounds. Okay, we are done with the classifications. What are the factors that affect wound healing? So factors can have log factors such as infection, presence of necrotic tissue and foreign body, can have poor blood supply, venous or lymph stasis, can have tissue tension, hematoma, large defect or poor position, can have recurrent trauma, can have X-ray in an area which is X-ray irradiated, or there is a radiation in an area continuous. It affects wound healing. Site of wound, that's the 10. So e.g. wounds over the joints and back as poor healing. Then 11 can have underlying diseases like osteomyelitis, malignance, and also mechanism and type of wound. So like we said, the mechanism of wounds such as incised, lacerated, crash, avulsions, they have their own their way of healing. So depending on the mechanism of wounding, it can affect even the wound healing. Okay, then you have general or systemic factors. Then under general or systemic factors, we can have age, obesity, smoking, can have malnutrition, vitamin deficiencies such as vitamin C, can have anemia, can have malignance, uremia, jaundice, diabetes mellitus, can have other metabolic diseases, can have HIV and immunosuppressive diseases, can have steroids and cytotoxic drugs, can have neuropathies of different cause. So those are the factors that affect wound healing. The under phases of wound healing can have the mnemonic HIPR, which is hemostasis, inflammation, proliferation, and remodeling. Then if they were to ask you the stages of wound healing, the mnemonic is IGESM. So I is inflammation, G granulation tissue formation, E epithelialization, S scar tissue formation, then M maturation. So maturation is also called remodeling. Okay, so we are done. This is our last station. So describe what you see, what is a fracture, how do you classify fractures, what are the complications of fractures. So as you can see, this is a mid-shaft duodenum. fracture, and you can see there is a complete displacement of the ulna. There's complete displacement of the ulna as well as the radius, although there is some contact on the radius. Okay, so what is a fracture? So this is a break or rupture in the continuity of the bone with soft tissue injury, with or without neurovascular damage. They now do classify fractures. So the mnemonic is ACRES, ACRES. Where we have the so on the ACRES: A anatomical, C clinical, R radiological, E etiological, then S for specials. Then so we have etiological classification, etiological, where we have traumatic. The trauma could be direct or indirect. Then we can, under the same etiological, we can have pathological fractures, and have some are spontaneous, some are of trivial violence. Then you can also have stress or fatigue fractures under etiological. Then in clinical, you can have simple or closed, you can have compound or open, or complicated, meaning a compound is one which is open. So most people mistake a compound for one which combines open and close. No. In the geological, we can have transverse, oblique, spiral, where a bone is twisted apart. Then we can have comminuted, where the bone is splintered or crushed. We can have segmental, avulsion, or distraction caused by traction. And then a bone fragment usually being torn off by a tendon or ligament. And then you can have a butterfly, you can have green stick, which occurs commonly in children, whose bones are soft and yielding, where we have the bone which bends without fracturing across completely, and the cortex of the concave side usually remains intact. Then have impacted, where we have one fragment is firmly driven into the other. You can also have compression. In anatomical classification, you can have diaphysis, metaphysis, epiphysis, and so on. You can have specials classifications. Under specials, this is where we have like Castello Anderson, Gatland, Boyd Griffin, Pipkins. So there are a lot of special classification of fractures. Principles of management of fractures: we have the 4 R's. We have resuscitation, reduction, immobilization, or holding or retention. We also have rehabilitation. Then the resuscitation part is in the context of high energy injuries, because one which is not high energy or it's not open, you might wonder why you need for resuscitation. But this is to help you remember that always, even in fracture, resuscitation is there. So if it's an open wound, during your resuscitation, you're going to do your fluid, you give your antibiotic, you do your wound irrigation and debridement. Those are some of the things you can do in resuscitation. I mentioned 5 complications of fractures. So 5 complications. So remember, in fractures, in surgery, we have immediate or aid complications. We have hemorrhage, which may lead to shock. Hence the need for it to cannulate and give you fluids or blood where if necessary. So under the same hemorrhage, we have internal and external hemorrhage. So for femur fracture, expect 2 liters. Then for a tibial fracture, expect half liter. Then for pelvic, expect about 3 to 5 liters of hemorrhage. The nerve or vascular injury can have soft tissue injury, e.g. in visceral organs or urethritis. Then you can have tendon injury. So the way I remember immediate is you can have hemorrhage, then the injuries: nerve injury, vascular injury, soft tissue injury, tendon injury, so that you know that those are immediate or early complications. Then intermediate, we can have vascular necrosis, amputation, compartment syndrome, joint stiffness, Volkmann ischemic contractures, osteomyelitis, fat embolism, thromboembolism, We can have a septic wound, we can have septicemia in compound fractures. In the underlate, we can have malunion, which may lead to late neuropathies, e.g. a valgus deformity at elbow, an ulcer or non-union, delayed union, and have osteoarthritis, which is common and particular fractures, especially in displaced. You can have joint instability or deformity. You can have post-traumatic atrophy. You can have osteochondrosis, which is an brittle. And you can have osteoarthritis. You can have shortening of bone. You can have intra-articular and peri-articular adhesions. You can have also hypostatic pneumonia, DVT, and pressure sores. So that's the end of the tutorial. Thank you for watching. If you haven't subscribe and hit the bell notification, and check out other OSCE stations, because this is our third OSCE station in surgery and we are not repeating any of the OSCE stations we have done. Thank you. See you.